Sono le 11. It is 11, and we would like to keep the hours. There are some photocopies you will find in the center of the table. Most of you might have already. And it's my pleasure now to give word, yes, to Professor Fins. Alessio, puoi chiedere per piacere per cambiare le slides?
Just start. Okay, thank you very much. It's really an honor to be here. It was on. Okay. Yeah, it's an honor to be here, and I thank the organizers for the invitation. What I'd like to do this morning is to borrow. Interestingly, I didn't read Diego's talk before I made my talk, but I'm going to be talking about nosology and convergence, and also invoking Aristotle along the way. Which seems to be the task du jour. When scholars write about personalized medicine, most refer to the interpretation of molecular biomarkers for the development of therapeutics tailored to an individual's disease. By moving beyond pathological phenotypes to better characterize disease and guide treatment, next-generation personalized medicine moves more deeply into the biology of the malady to refine diagnostics at a genotypic or molecular level. By understanding the unique biology of an individual's disease, in most cases, thus far, a malignancy personalized therapies can be directed against specific biological targets. This maximizes therapeutic effect, decreases variance of therapeutic response, leads to more accurate diagnostic classification, and can minimize side effects. I will suggest another domain where the metaphor of personalized medicine is apt, and consider its application in the realm of neuropsychiatric conditions. To do this, I will invoke the example of emerging diagnostics, therapeutics, and neuroethics related to the care of patients with disorders of consciousness. These conditions comprise a range of brain states that span coma, the vegetative, and minimally conscious states, and each of these states have behavioral and biological characteristics that warrant review and consideration for our discussion of personalized medicine. It also gets to the essence of the person because we're talking about consciousness. With disorders of consciousness as well as cancer biology, overt presentation and underlying biological mechanisms may be discordant. Patients presenting similarly at the bedside as phenotypically may have meaningful differences in their underlying neurologic circuitry. These distinctions, or the discordance between observed phenomenology and unobserved neurobiology, can have normative implications for the diagnosis and treatment of these conditions. And I just want to draw our attention to Vesalius's print here of the skeleton contemplating the skull, and that looks primitive in our moment in history, and I suspect that what we're doing now in a few hundred years will look similarly primitive. And I think the point of the end of the conversation after Diego spoke is that this is an evolving story. That the story as we know it today this is sort of the schema of what we're talking about, and these are the brain states. And let me just review the prevailing nosology that we consider. When a patient loses consciousness, it can return without incident, such as if you fainted or you've had general anesthesia. But in the cases of severe trauma, metabolic, or anoxic brain injury, the duration and nature of impairment can linger. And for our considerations, these have been characterized by people's behavioral manifestations, that is, responsiveness and neurological findings on the bedside clinical exam. To introduce a metaphor from genetics so important to personalized medicine and cancer care therapeutics, what we see at the bedside might be best thought of as a neurological phenotype, These phenotypes vary by brain state. For coma, it's characterized by an eyes closed state of unresponsiveness. It's self-limited, usually lasts about a couple of weeks. The next brain state we're going to talk about is the vegetative state. And this is where I'm going to bring up Aristotle. Fred Plum, who was the co-originator of the vegetative state, an American neurologist who was my teacher and my mentor, and Brian Jeanette, who's the Scottish neurosurgeon who's also known for the Glasgow Coma and the Glasgow Outcome Scales. They came up with the vegetative state by referring back to Aristotle and de anima, of the vegetative capabilities described there. They first described the vegetative state in the Lancet in 1972 as a state of wakeful unresponsiveness, great phrase, in which the eyes are open but there's no awareness of self, others, or the environment. These patients have sleep-wake cycles and even a startle reflex, but are unconscious. And depending on how long this lasts, it's been characterized as persistent or permanent. If it lasts for a month, it's persistent. If it lasts over 3 months after traumatic brain injury or 12 months after traumatic brain injury, it's designated as permanent as up to September of 2018. In 2018, after a 5-year deep dive into the literature, an evidence-based review, the American Academy of Neurology, the American College of Rehabilitation Medicine, and the NIH's Institute on Disability, Independent Living, and Rehabilitation Research promulgated new practice guidelines related to the vegetative and minimally conscious states and the care of these patients who tragically go underserved in a kind of a custodial care system. And I was honored to write the accompanying ethical policy and palliative care considerations related to these practice guidelines that were published jointly in Neurology and Archives of Physical Medicine. Interestingly, for the broader context of the right to die movement and the like, they changed the permanent vegetative state to the chronic vegetative state because it seems that 20% of people who were heretofore thought to be permanently vegetative may actually go on to a higher brain state, and we'll get back to that. These guidelines are important for that reason. The next brain state up is the minimally conscious state, and this is from the Aspen criteria of 2002. Those are actual aspen trees in Aspen, Colorado. I took that with my iPhone. These patients are people who have evidence of consciousness and awareness. They have intention, attention, and memory. They might reach for a cup. They might look up in their room. And they have the circuitry that undergirds this, but they do this episodically and intermittently. And you actually have to see a patient at least 5 times at different times of the day to capture it. And their highest degree of function is determined by their most evolved exam. And just to give you a sense of how difficult this is, 41% of patients in nursing homes after traumatic brain injury who were thought to be in the vegetative state, when carefully interrogated, are actually in the minimally conscious state. We now appreciate, and this is where the discordance between the genotype and the phenotype become apparent, we now appreciate from emerging neuroimaging data that the underlying biology or the genotype of the vegetative and minimally conscious states are dramatically different. Patients who are vegetative have autonomic functions that are really grounded in the brainstem without higher integrative function. When presented with a stimuli, and this is a paper on the top screen of a pain stimulus, you see on the top controls and on the bottom patients in the vegetative state, normal controls will activate what is described as the pain network, which is in red. The vegetative patients will not light up the pain network, only light up the primary sensory areas, and what you see in blue is the absence of activation. So what you see here is the lack of a network response, the lack of an integrative response. In the lower panel, you see a study that was done at Cornell by my colleague Nico Schiff and others, in which patients who were minimally conscious were played language forwards and backwards. At the bedside, they looked sort of behaviorally unresponsive, except for these intermittent responses. But when you played these tapes of family narratives, remember when we were kids and mom took us to the beach and it was usually read by a relative, when you played it forward, they lit up language areas in the brain. When you played it back with the same frequency spectrum, they did not respond. So they responded to language, but not to gibberish, which suggested some degree of awareness and consciousness. This led to my being interviewed in the New York Times on the right side panel there by Ben Carey on the front page, and I made this quote, which I can't read from here, that it gave me goosebumps because these people are there, but we've been thinking that they weren't there all along. And this was happening right in the midst of the Terry Schiavo debate. Okay, so a failure to adequately distinguish the vegetative state, which Terry Schiavo was in, from the minimally conscious state has profound ethical implications. If a patient is misdiagnosed by phenotype as vegetative, when in fact genotypically they're in the minimally conscious state, they can be thought to be insensate and unable to experience pain, and these patients are often not treated for pain when they have the network that could accommodate pain responses. And I've talked about this in a number of venues, but I think this is a human rights, a basic human rights issue, and we have to think about the neuropalliative care of these populations, which gets to the center of the distinction between genotype and phenotype. I've described this as a human rights issue and a disability rights issue. I've written about it in the New York Times, and at Yale Law School, we write about the legal implications of this as well. And herein lies the problem. For a phenotypic characterization of patients with disorders of consciousness, it may be inaccurate and thus biologically misrepresentative. While a vegetative and minimally conscious patient may have similar phenotypes, even if carefully assessed, their neurologic genotype grounded in the circuitry of their distinct underlying neural networks can be quite distinct. Because MCS patients have these intact neural networks, they're biologically different, and they can easily be confused or conflated with vegetative patients. I described the disconnect between observed phenotype and genotype in patients with intact networks in a number of contexts. And the first study on the top part of the screen there was a study done by Adrian Owen, published in Science in 2006, got headlines around the world about a patient who was clinically vegetative, but when asked to imagine walking around her house, playing tennis, and disaggregating a riverbed creek and a creek in your neck, lit up their motor, spatial, and linguistic areas as if they were normal. This was at 5 months. At 11 months, in the supplementary materials, which nobody commented on, she had already moved behaviorally to the minimally conscious state. And the most sensitive way to assess those patients behaviorally or phenotypically is you put a mirror to their 45 degrees to their eyes and they'll look at the mirror. So she had reached the minimally conscious state. However, a lot of patients will simply be in this non-behavioral where they have the genotype or the circuitry, but they don't express the phenotype. And this could be, quite significant. More recently, this idea has been expanded to describe it as this covert consciousness, right, as cognitive motor dissociation. And we are now seeing this not only in chronic patients, but even in the ICU. This is a paper by Brian Edlow, with whom I've written, and I wasn't part of the second paper, that published in Brain, of early detection of consciousness in patients who have had traumatic brain injury in coma in intensive care units. And this has prognostic significance because people often look like they have no future, but in fact, this may be predictive of eventual recovery. The challenge of the discordance represented by cognitive motor dissociation is akin to that seen between phenotype and genotype in conventional Mendelian genetics and contemporary discussions of personalized medicine. And this is, of course, a picture of the Augustinian monastery of St. Thomas in Brno in Czechoslovakia, where we all have great debt to a monk in Brno. Those of us who have treated cancer patients with seemingly the same disease have had patients with variable outcomes. This has made prognostication difficult. Why are these patients responding so differently to the same treatment? With the advent of genetic arrays, we now appreciate that what appeared to be the same disease histologically were in fact biologically distinct. Considering cancer genetics, these conditions were different. They responded differently to the treatment because they were different. With this realization, prognosis and treatment has evolved, with each informed by a more sophisticated set of biomarkers. When I was a resident and I rotated across the street from Cornell, New York Hospital to Memorial Sloan Kettering Cancer, I remember treating patients with the dreaded acute promyelocytic leukemia who did worse than their peers. They had horrific bleeding, diatheses, and were paradoxically treated with heparin to quell this complication. Of all the AML subtypes, this is the one to avoid. But today, with a deeper knowledge of APL's biology and the advent of targeted therapy, which all transretinoic acid, this is one of the AML subtypes that you would actually want to have, even though 30 years ago it was one you didn't want to have. There are, of course, other examples. The challenge with disorders of consciousness is that we are several decades behind the progress that's been made in other areas in personalized medicine. We're in this transition phase, and we were talking about that transition phase, Diego, in your talk, between behavioral criteria and a fuller understanding of the circuitry or the genotype, which better characterize these conditions. And with the advent of functional imaging, it's almost as if we have just discovered the microscope. That's sort of where we are. This presents a problem for prognostication and speaking with families, and Dr. Mozam and I were talking about this at break, and Lee's comment about education, how critical it will be to have scientific literacy amongst the people we're talking to get consent, because we are in between two paradigms, the behavioral paradigm using the coma recovery scale, and we're transitioning to neuroimaging criteria, which is more deeply based in the circuitry. While a physiologic approach to understanding will be useful in the longer term, we're still left with cruder metrics. And the challenge is, how do we use behavioral tools or phenotypic tools in conjunction with new techniques that are yet to be totally vetted, like neuroimaging and EEG? In the long run, this combination will yield a powerful synergy, like Lee described for his people, although it can produce confusion and mixed signals in the short term, making conversations with families especially challenging. Knowledge is power, and our knowledge base is expanding dramatically. The challenge is that we still know less than what we need to know. Today we have a whole new suite of questions which we did not need to grapple with before. Here, scientific advance presents us with a paradox. New knowledge can lead to increased uncertainty and be disempowering. Consider the question of covert consciousness. Before we had neuroimaging, we had no knowledge of its possibility. Our assessment was based on what we saw at the bedside, and we realized what we saw. Now we are not so sure. Neuroimaging has expanded our knowledge and presented us with a normative problem for which we still don't have a reliable solution. An associated challenge posed by our advances in knowledge is presented by the newly designated chronic vegetative state, which is a new phenotypic category based on this emerging genotypic knowledge. If 20% of patients, once thought to be permanently vegetative, have the prospect for additional recovery, how long is it prudent to wait for that recovery to occur? At what emotional cost for families and economic ones for our society? We are in a period of tremendous intellectual advance, but with this progress comes new ethical challenges of which we were once blissfully unaware. Where once clinicians thought they knew unconsciousness when they saw it, now we can't be so sure. Consciousness may lurk behind the surface unrecognized, or it could reappear with the tincture of time and or novel therapeutics. And this leads to personalized medicine and emerging therapeutics for this population. Like personalized medicine and cancer biology, which is grounded in generalizable pathways, neuromodulation is based on an emerging knowledge of the circuitry of consciousness and its disruptions. As certain molecular-based illnesses are caused by discrete pathological abnormalities that operate within known systems, neuropsychiatric conditions have dislocations within constituent circuits. Most recently, the mesocircuit has been identified as a key circuit that plays a role in consciousness and its disruption. Simply depicted here in this cartoon version, the mesocircuit links the thalamus, which is kind of the thalamus is to the brain what Hartsfield Airport is for Delta Airlines. It's the hub. You can't get anywhere from here unless you go through Atlanta. It's the node through which everything is connected. And we now know the brain is connected through cortical thalamocortical tracts. And what you see here, the thalamus looks down into the brainstem, which provides arousal. So you need to be awake to be conscious, but a wakefulness without awareness is the vegetative state, and that's the brainstem. But you need then to integrate, and the cortex gets integrated through the thalamus, and you can activate this in a number of ways through direct activation, through glutamatergic pathways, through deep brain stimulation, or drugs like dopamine and zolpidem, which inhibit inhibitions that then release thalamic output up into the cortex. And this is described here. And this is something that we did. Our group in 2007 pioneered the manipulation of this system with the first use of deep brain stimulation in the minimally conscious state. Our work was published in Nature and demonstrated the ability of stimulating the intralaminar nuclei bilaterally in the thalamus using a pacemaker for the brain as used for Parkinson's disease to improve cognitive function in a severely injured brain. In this proof of principle, first in human study, double-blind crossover methodology, a patient who had been stable in the minimally conscious state for 4 years, who was unable to communicate except to occasionally blink an eye, could not eat by mouth, and had impaired motor and postural control, was able with deep brain stimulation to say 6 or 7 word sentences, say the first 16 words of the Pledge of Allegiance, go to Old Navy and choose clothing with his mother. He could tell his mother he loved her, talk about the family connections here, and he could eat by mouth for the first time in 6 years since he had been brutally assaulted in Paterson, New Jersey. I describe this in my book and the family saga. From a normative point of view, for me, the highlight of this was, we talk of it, agency ex machina. This was agency ex machina, deus ex machina. This is agency ex machina, the restoration of personal agency through a neuroprosthetic device, not at the level of consent and refusal, but assent and dissent. And we were doing stimulation parameters one afternoon in New Jersey, where he resided in his facility, and the electrode has 4 prongs on it. And every time you change something, you have to go back to the beginning and take biometric measurements. And it was exhausting, a hot summer day. And his name was Greg Pearson, and I had permission to use his name. And one of the physiatrists said, "Greg, do you want to continue?" And he said, "No." And I looked at my watch, and I wrote the time down. And this was the restoration of this ability of this person to come back into the room and participate in the conversation. And to me, that was a highlight of this lost personhood being rediscovered through a neuroprosthetic intervention. Like molecular-based medicine, the provision of emerging therapeutics, mostly in the investigational stage, requires skilled diagnostic assessment that transcends bedside examination, which is conversant with these circuit-based arrangements. Like molecular-based personalized medicine, we envision a new nosology which will emerge based on these therapeutic targets. This would represent a transformational change, maybe not paradigmatic change, we'll debate that, and how these conditions are categorized and move robustly from a behavioral to a circuit-based classification. Until that occurs, we can assert before we can assert generalizable patterns from a collected experience of engaging in this probative biology, itself a product of therapeutic investigation, such as our work using DBS, we'll be in a state of personalized medicine by default. We will try to apply incomplete data sets in a particularistic way to individual patients with unique brain patterns. This will lead to interventions that appear, like Lee was talking about, as N of 1 cohorts until data can be aggregated into predictable patterns. And one of the great challenges we have as we assess patients for these interventions is to study them in depth, look at their biology, look at their circuitry, look at their neuroanatomy, and other factors to see whether or not they're candidates for this personalized intervention. This methodology, as essential as it is at the frontiers of knowledge, makes the traditional metrics and ethics of randomized clinical trials impossible. It calls for a different regulatory approach. And I was wondering, listening to Diego, if the paradigm is not a paradigm shift, but it might be a paradigm shift in methodology, is what we're talking about, moving away from randomized clinical trials. And it requires a different approach, and what the philosopher of science Miriam Solomon, this Oxford University Press book, has described as a pluralistic way of knowing in different ways. She suggests that we need both methodological rigor as well as knowledge of mechanism and the integration of personal narrative. What Barbara actually, I think if you talk about this in your talk, will describe as thick data. In addition to, and she's saying, we've had a kind of obsession with the randomized clinical trial, and we need to move beyond that. This has bearing on ethical and regulatory questions about informed consent disclosure and discussions of proportionality. And of course, there is the additional epistemic complication when considering neuropsychiatric conditions. Whether one is attempting to restore and give voice to consciousness, as my colleagues and I have tried to do, treat drug-resistant depression as the neurologist Helen Mayberg has done, treating depression with deep brain stimulation, or live with Parkinson's disease, the question arises about the personal nature of the outcome. What are the goals and who decides them is perhaps the ultimate question of personalized medicine and the continuity of the true self. Fundamentally, then, what we are witnessing in the demarcated clinical landscape of disorders of consciousness is an epistemic transition between what is observed and what is understood. This transition represents a move away from well-worn patterns of practice informed by decades, if not centuries, of diligent clinical observation into a state of personalized care informed by the particularities of a patient's injuries. In time, those responses to personalized therapeutics hopefully will be aggregated in some generalizable findings applicable to groups of patients of which these individuals will be subsets. When this occurs, investigators will come up, I believe, with a new nosology that replaces the descriptive one upon which we have so long relied. This new diagnostic classification will not solely be grounded in what is observed, but the responsiveness of circuit derangements to neuromodulation. In this way, which could also be used in a non-invasive way, using optogenetics or transcranial magnetic stimulation. Having to actually go and put an electrode into somebody's brain is what Lewis Thomas called the halfway technology, and we might evolve into less invasive technologies. In this way, using these probative devices, we'll improve diagnostics, prognostication, and refine therapeutics for this population. If we achieve this objective, traversing the perils of an intervening period of indeterminacy, which can be perilous, we will have fulfilled an ancient mandate of medical inquiry as described by the great physician Sir William Osler, a founder of Johns Hopkins Hospital and School of Medicine and one of the founders of my field, internal medicine, and late Regius Professor of Medicine at Oxford. In his classic, The Leaven of Science, Osler observed the following. This was in Equanimitas. He said, "The determination of structure with a view to the discovery of function has been the foundation of progress." I believe that this period of so-called personalized or precision medicine is part of this Oslerian journey. It only seems personal because we need to make our discoveries one person at a time. But this quest is in a long tradition of medical inquiry, pushing back the shrouds of ignorance so that patients individually and then collectively will benefit from the foundation of progress that has sprung from our careful interrogation of function and its variance in disease and injury. Thank you very much.